In this presentation, we will talk about how to analyze hypnogram, and we will discuss very common interesting cases. The hypnogram is traditionally the compressed graphic summary of sleep stages for the whole recording period. In modern sleep technology, and depending on the type of the study, you can formulate the summary graphs accordingly to include respiration and body position, oximetry, CO2, heart rate, PAP summary, and motor events. In polysomnography, the summary graph should have the hypnogram, which gives a summary for the sleep stages across the night, where you can assess the sleep continuity and sleep consolidation. Also, you can evaluate the common characteristic pathological patterns which are related to circadian rhythm problems. Body position that helps to diagnose position-related disorders. Also, this is very important in determining optimal pressure of titration. SpO2 summary. This will help you to identify the baseline, and it will help you to recognize the saturations and the periodicity of those desaturations. Respiratory event summary helps you diagnose respiratory related problems. Also, it's helpful to distinguish optimal pressure of titration. This graphic summary belongs to a normal individual, where you can see normal sleep cycles with no respiratory component and normal oxygenation. To analyze summary graph, evaluate the graphs horizontally. So, you have to evaluate the flow of sleep stage across the night, oximetry profile, and the occurrence of respiratory events. Then, interpret vertically to understand the relation between sleep stages, body position, respiration, and oxygenation. Analyzing summary graphs allows clinicians to distinguish very common characteristic patterns like obstructive sleep apnea dominant or related to body position, REM dominant related hypoxic sleep disorders, excessive somnolence, circadian phase disorders, and central sleep apnea disorder. Case number 1. 61 years old male with a history of hypertension and diabetes, history of choking and excessive daytime sleepiness. Epworth Sleepiness Scale was 9. Nocturnal PSG was done for that patient, and here we have the summary graph. Let's have a look into the segments of that summary graph. If we look into the hypnogram, we have frequent arousals. If we look at the sleep continuity, it is severely fragmented. How about REM latency? Do we have sleep onset REM? The answer is no, because the first REM happened after more than 90 minutes from sleep onset. Body position. The patient slept on various positions including supine. SpO2 summary. How about the baseline? Is it hypoxic? No. How about the desaturations? We have severe, significant, and periodic desaturations. Respiratory events. Do we have respiratory events over here? We have frequent episodes of obstructive apneas and obstructive hypopneas. We have some infrequent episodes of mixed apneas, and we don't have central events. How about the distribution of those respiratory events and periodicity? Those events disappeared in some particular locations. Now, we need to analyze the seminograph vertically in relation to body position to evaluate if this condition is only related to supine position. In relation to supine position, we have significant episodes related to supine position. In relation to non-supine position, and during non-REM, no events or desaturations were scored. During REM, significant events and desaturations were scored. The conclusion for this case and the diagnosis is severe REM-dominant obstructive sleep apnea. REM-dominant obstructive sleep apnea has the following findings. Desaturations and respiratory events occur in both of non-REM and REM sleep. However, in REM sleep, it becomes more severe and frequent. Case number 2. 56 years old male. Hallucinations, choking, excessive daytime sleepiness, and Epworth Sleepiness Scale of 14. This is the hypnogram of the patient. How about sleep continuity? It is fragmented sleep. How about REM latency? We have sleep onset REM latency because REM occurred at less than 90 minutes from sleep onset. When SOREM is registered, this might indicate the following causes: narcolepsy, circadian rhythm disorders, abrupt withdrawal of REM suppressants, depression, sleep deprivation, and chronic sleep fragmentation. Looking at the history and other polysomnographic findings will help you to differentially diagnose the condition. In SOREM patients, if there is a respiratory component, do the following. Titrate the patient and reach the optimal pressure of titration. Another night under PAP optimal pressure is required. Inspect for the following findings throughout the study: sleep onset REM, frequent arousal index, periodic limb movement, sleep during REM stage. Straight after, run MSLT in the next morning. Case number 3. 54 years old male, history of hypertension, presented with witnessed apnea, and history of excessive daytime sleepiness. This is the hypnogram of the patient. Do we have arousals? We have frequent arousals, especially in the first part of the night. How about sleep continuity? Sleep architecture is severely fragmented, especially in the first half of the night. That became more consolidated on the second part of the night. How about SOREM? No SOREM was registered in this hypnogram. Body position. Mainly, the patient slept on supine position. PAP summary will give you the study type. Here, you can know that this is a split night study because it was started at atmospheric pressure, then a certain part of the night, CPAP was applied until the end of the recording. SpO2 summary. How about the baseline? It's non-hypoxic. Desaturations. There are severe desaturations and significant, especially during the first part in a particular location. In the second part, residual insignificant desaturations in a particular location. At the end of the study, frequent significant desaturations in a particular location. How about respiratory events? In the first half, there were significant obstructive episodes. In the second half, there were insignificant obstructive episodes. At the end of the study, there were significant residual obstructive episodes. This is the overall summary graph for that case. Let's go vertically to interpret sleep stages in relation to body position and respiratory events. Is that related to exclusive body position? In this diagnostic part, the patient slept only on supine, so we don't know about non-supine. Is it related to REM sleep? During non-REM sleep, frequent episodes of obstruction were evident with obvious desaturation, which means that it's non-exclusive to REM sleep. How about severity and dominancy? During REM sleep, frequent episodes of obstruction were evident with more significant desaturations comparing to non-REM. Is it optimal pressure of titration study? Was the patient achieved in REM stage and supine position? Yes, it was. He progressed into 2 cycles of REM at the end of the study. Was his condition optimally titrated on pressure 9 cm H2O in REM sleep and supine position? The answer is no. In the rounded rectangle, there were some residual hypopneas. Was his condition optimally titrated on pressure 10 or 11 cm H2O? No. The pressure was increased rapidly, where frequent respiratory episodes were noted with obvious significant desaturation. Another titration night should be repeated in order to identify the optimal pressure for this case. Split night summary graph helps assessing the quality of titration and determining optimal pressure of titration. Case number 4, 50 years old male, history of congestive heart failure, shortness of breath, and excessive daytime sleepiness. Polygraphy was done for that patient, and here is the summary graph. From the summary graph, if we look at the SpO2 summary, we will see symmetrical, moderate, sawtooth desaturation. And this is one of the characteristic patterns for central sleep apnea. If we look down to the respiratory events, we can obviously see that a lot of central apneas and hypopneas were scored. Case number 5. We have a 21 years old female, increased sleepiness over past year. She had an adequate sleep opportunity, history of refreshing naps, no cataplexy or sleep paralysis, hallucinations, and vivid dreams were observed. This is the summary graph of that patient following nocturnal polysomnography. Going to the hypnogram, do we have arousals? Very frequent throughout the study. How about sleep continuity and the presence of SOREM? Fragmented sleep with 5 REM cycles with no evidence of SOREM. How about desaturations? Stable oxygenation. How about respiratory events? Free. PLMS, also free. MSLT study was performed straight after that nocturnal polysomnography to isolate and to differentially diagnose the condition. The patient was given 4 naps and he did not progress into REM sleep in any of those naps. If you look at the MSLT hypnograms, you will see that the patient progressed only into non-REM sleep. To conclude, mean sleep latency was 3.6 minutes for all of the 4 naps, which means that this is hypersomnia, and the count of SOREMs is 0 out of 4. Going from that conclusion, this will support the diagnosis of idiopathic hypersomnia. Case study number 6. We have 61 years old male with Parkinsonism. April sleepiness scale is 11/24. Snoring, non-refreshing naps, and bruises. Realizing the association between Parkinsonism and REM sleep behavior disorder, video recording is crucial to support the diagnosis. This is the summary graph of the patient after nocturnal polysomnography study. We have very frequent arousals throughout the study and minimal in REM sleep. How about sleep continuity? The sleep architecture is severely fragmented. How about the occurrence of SOREM? Yes, there is a SOREM. Looking into the PLMS, the periodic limb movement during sleep, we have severe and more evident in some particular locations. Looking at the respiratory event summary, we have infrequent episodes in some particular locations. This will indicate that the arousals are non-respiratory arousals. If we look here at this section, and if we correlate the REM periods with the intensity of the PLMS, we will be able to visualize that periodic limb movements during sleep were evident severely during REM periods. Looking at the total AHI, if it fulfills the criteria for PAP treatment, titrate PAP and reach optimal PAP pressure. Nocturnal polysomnography with PAP optimal pressure is required. Video recording. If SOREM arousals and PLMS during REM persist, conduct MSLT the next morning. This presentation is finalized.